Hi, I'm Krina Patel. I'm an associate professor at MD Anderson Cancer Center in Houston. I'm actually the multiple myeloma section chief and research lead as well. Yeah, actually, it was a great project to be a part of. We have a U.S. consortium for immunotherapy that just keeps growing by the month, which is really exciting. It's a lot of our wonderful junior faculty as well as a few senior faculty, and it's a great group to work with. And we've had multiple projects, but this was the first project that actually is comparing different options for myeloma. And, in myeloma, we have great therapies that are coming out and multiple therapies that sort of have similar mechanism of action, or, they go after the same target on the myeloma, but there's no prospective studies that compare them. And so we really are left with, anecdotes of, okay, I think this works better in these patients versus this works better in these patients. And so we know retrospective evaluations have limitations. And so for this study specifically, I think Dr. Hansen did a phenomenal job. She was the first author of really looking at retrospective data and trying to figure out ways to really just have no bias or minimal bias in terms of even timing of when we were looking at patients who got treated. So again, patients who got treated as standard of care with either Ide-Cel, which came out first, right? It was approved before Cilta-Cel, like a whole year before Cilta-Cel was, versus Cilta-Cel that basically were in late line therapy. And what she was able to do is we had over 600 patients, and it came down to 550 or so patients that got either of the cell therapies. And then she did some great statistical work where, she really looked at the IPWT and all these things of different aspects. So patients who responded to bridging or not, looking at age versus high risk, standard risk, all the major players in myeloma that could affect outcomes, as well as the logistics, as I said, only using patients who got Ide-Cel, only using their data if it was after Cilta-Cel was already approved, to try to avoid that bias of when, we learn for the first time when something comes out, and by the time the second drug comes out, the second cell therapy comes out, we're much better at it, and we know how to take care of patients better. So to try to get all that out, she really did a fantastic job, the best that I think she could have. And our team did a great job of actually being able to compare the two. And in the end, what the answer really was, Cilta-Cel is a much stronger, more efficacious product compared to Ide-Cel for the majority of patients, but it's also the more toxic. And so the bigger question that comes out now, in terms of efficacy, great, we know that's better, but certain toxicities, especially certain delayed neurotoxicities like the Guillain-Barré or the Parkinsonianism or secondary cancers, or even colitis that we're seeing, they tend to be more aggressive or happen more with Cilta-Cel. So it really comes down to being able to talk to our patients to say, hey, this is the data we have. And yes, the efficacy here is better, but the efficacy here is this, but the toxicities are also different. And I think that's actually what this research is so great about. We actually can apply it to the patients we see in clinic and really make decisions together. So there's more coming from that, from the same group of now comparing other products, or, seeing what maybe older patients or those who have more comorbidities maybe, are there other options for them instead? But again, more than just the data, I think the process of this retrospective series was pretty impressive and a joy to be a part of, and I got to learn a lot as well.